Welcome to Chapter 10 of the BCSC, where we will explore systemic disorders with corneal and other anterior segment manifestations. The cornea and anterior segment of the eye often serve as windows into systemic health, reflecting the presence of a wide range of systemic disorders. Because of their unique anatomy and physiology, these ocular structures can manifest early changes that alert clinicians to underlying metabolic, autoimmune, infectious, or genetic conditions. Recognizing these manifestations is crucial, as ocular findings may precede systemic symptoms, thereby aiding in earlier diagnosis and management of potentially serious diseases. By the end of this chapter, you will gain a deeper understanding of how ocular examination can reveal critical insights into systemic health, reinforcing the importance of the eye as both an organ of vision and a diagnostic tool for systemic disease. Let's get started. The clarity of the cornea is vital for normal vision, but this clarity can be disrupted by the deposition of substances such as carbohydrates, lipids, proteins, or nucleic acids. The anterior segment of the eye may also be affected by a wide spectrum of systemic conditions, including autoimmune, dermatologic, musculoskeletal, and other systemic diseases. Recognizing these manifestations is key because early diagnosis and timely medical intervention can prevent irreversible ocular damage and improve overall patient outcomes. In this chapter, we will review the systemic conditions that impact the cornea and anterior segment, emphasizing the importance of careful observation and interdisciplinary collaboration in identifying ocular signs of systemic disease. Let's start by talking about inherited metabolic diseases, specifically lysosomal storage diseases. There are many different types, but we will focus on the most common ones. Lysosomal storage diseases are caused by mutations in lysosomal enzymes, which are responsible for breaking down complex molecules such as proteins, carbohydrates, lipids, and nucleic acids. When one of these enzymes is missing or dysfunctional, the degradation process is impaired. This leads to the accumulation of undegraded material within cells, particularly in lysosomes. To date, over 30 distinct lysosomal storage diseases have been identified, each associated with a deficiency in a single enzyme. The buildup of these materials has widespread consequences, resulting in both systemic disease and ocular involvement. In the eye, these deposits often disrupt corneal clarity and can also affect other anterior segment structures, ultimately impairing vision. Systemic mucopolysaccharidoses (MPS) are a group of rare inherited lysosomal storage diseases that occur in approximately 1 in 10,000 births. They result from defects in enzymes responsible for the breakdown of glycosaminoglycans, which leads to the accumulation of these substances in keratocytes, the corneal epithelium, endothelium, and the extracellular matrix. This buildup causes corneal clouding, a hallmark ocular manifestation, and is often accompanied by a range of systemic abnormalities. Most forms of MPS are inherited in an autosomal recessive manner, with the exception of Hunter syndrome, MPS II, which is X-linked recessive. Several subtypes have been described, including MPS I, Hurler-Shea and Shea syndromes, MPS II, Hunter syndrome, MPS III, Sanfilippo syndrome, MPS IV, Morquio syndrome, MPS VI, Maro-Tolami syndrome, MPS VII, Sly syndrome, and MPS IX, Natowich syndrome. Clinically, these disorders are important to recognize because they not only cause progressive corneal opacity, but also reflect widespread systemic disease, affecting the skeleton, connective tissues, and in many cases the central nervous system. This table provides a detailed summary of the different MPS syndromes, highlighting their inheritance patterns, enzyme defects, accumulated material, screening and diagnostic tests, and ocular manifestations. We will only talk briefly about the first 4 listed on this table and boxed in red, as these are the ones most commonly tested. MPS Ih, or Hurler syndrome, inherited in an autosomal recessive manner, is caused by a deficiency in alpha-L-iduronidase, leading to accumulation of dermatin and heparin sulfate. Patients show severe corneal clouding within the first few years of life, with diffuse punctate stromal opacities, though the epithelium and endothelium are spared. Other ocular findings include pigmentary retinopathy, glaucoma, optic nerve swelling and atrophy, and hypertelorism.
MPS 1S, shy syndrome, also due to alpha L iduronidase deficiency, presents with more slowly progressive corneal opacification, often leading to decreased vision by the second decade of life, with corneal edema and peripherally prominent changes. Glaucoma may occur in some patients. The intermediate phenotype, MPS 1HS, Hurler-Scheie syndrome, shows diffuse corneal opacification and may be associated with retinopathy. MPS 2, or Hunter syndrome, an X-linked recessive disorder caused by iduronate 2-sulfatase deficiency, also results in dermatin and heparin sulfate accumulation. It typically does not present with congenital corneal opacity, but corneal changes may appear later in life, especially in milder phenotypes. Other ocular manifestations include exophthalmos, hypertelorism, optic nerve swelling, atrophy, and retinopathy. All of them are screened using urine glycosaminoglycans and confirmed with an enzyme assay. We will talk about each individually in the upcoming slides.
MPS 1 disorders are caused by a deficiency of the enzyme alpha L iduronidase, leading to impaired degradation of glycosaminoglycans. The severity of the condition can vary depending on the type of amino acid substitution, resulting in a spectrum of presentations. Hurler-Scheie syndrome arises from inheriting one Hurler gene and one Scheie gene, producing an intermediate phenotype. Hurler syndrome, MPS 1H, is the most severe form. It typically presents with severe cognitive impairment and corneal clouding by the age of 1 year. Without bone marrow transplantation, affected individuals have a very limited lifespan. Scheie syndrome, MPS 1S, on the other hand, is a much milder form. Symptoms usually appear later, between 5 and 15 years of age, and may include progressive corneal clouding, though it may not be present at birth. Patients generally maintain normal intelligence and have a normal lifespan, though gradual vision loss may occur. Hurler-Scheie syndrome, MPS 1H/S, falls between these two extremes, with intermediate severity. Across all forms of MPS 1, ocular manifestations are prominent and most commonly include corneal clouding, retinopathy, and optic atrophy. The image shown highlights diffuse corneal clouding, a classic feature of Hurler syndrome. Hunter syndrome, also known as mucopolysaccharidosis type 2, is an X-linked recessive disorder, which means it primarily affects males. The underlying cause is a deficiency of the enzyme iduronate 2-sulfatase, leading to the accumulation of glycosaminoglycans in various tissues. This buildup is responsible for the systemic and ocular manifestations of the disease. Unlike Hurler syndrome, corneal clouding is notably absent in Hunter syndrome. However, ocular complications may still arise, including retinal degeneration and optic nerve atrophy, both of which can significantly impair vision. Systemically, affected individuals exhibit coarse facial features, skeletal abnormalities, and developmental delay, reflecting the multi-system involvement of the condition. A helpful way to remember Hunter syndrome is the mnemonic, X marks the spot. The X reminds us that Hunter syndrome is inherited in an X-linked recessive manner. Also, imagine a hunter aiming at a target. The hunter needs to see the target clearly. This connects to the fact that, unlike Hurler syndrome, patients with Hunter syndrome do not have corneal clouding. The laboratory evaluation of MPS disorders typically begins with a urine test to screen for glycosaminoglycans, which are abnormally elevated in these conditions. A more precise confirmatory test involves leukocyte or plasma enzyme assays to identify the specific enzyme deficiency. Management of MPS disorders can involve surgical, medical, and transplant-based approaches. Surgical management, such as PKP or DALK, may be performed for corneal clouding. However, the outcomes are often limited due to concurrent retinal and optic nerve abnormalities. Prognosis remains guarded because abnormal storage material can recur in the transplanted graft. Bone marrow transplantation offers another treatment option and has been shown to lead to partial regression of corneal clouding in approximately 1/3 of patients. Medical therapy includes enzyme replacement therapy, which is available for certain types of MPS and can slow systemic disease progression. Additionally, gene transfer therapy is an area of active research and holds potential for future treatment options, aiming to correct the underlying genetic defect. Sphingolipidoses are a group of rare inherited lysosomal storage diseases caused by the buildup of complex lipids such as gangliosides and sphingomyelin within the corneal epithelium. These disorders result from specific enzyme deficiencies that impair lipid degradation, leading to progressive accumulation of substrates in various tissues, including the eye. There are four main conditions within this group: Fabry disease, multiple sulfatase deficiency, generalized gangliosidosis, GM1 type, and Tay-Sachs disease, GM2 type. A table at the bottom summarizes these pathologies. The clinical features of sphingolipidosis often include distinct ocular manifestations that serve as important diagnostic clues. The classic corneal finding is cornea verticillata, which appears as whorl-like lines in the basal epithelium of the inferior central cornea. This presentation is strongly associated with Fabry disease, but can also be seen in other conditions or with certain medications, most commonly amiodarone. Other ocular findings include periorbital edema, posterior spoke-like cataracts, and conjunctival aneurysms, which reflect vascular and metabolic involvement. Less commonly, patients may develop more severe posterior segment complications such as retinal or macular edema, papilledema, optic atrophy, and vascular dilation. These manifestations highlight the systemic and ocular overlap of sphingolipidosis and emphasize the importance of comprehensive eye examinations in aiding early diagnosis and management. The adjacent image demonstrates the characteristic cornea verticillata with subtle whorl-like opacities radiating from the inferior cornea, reinforcing the diagnostic value of slit lamp examination. The clinical features of sphingolipidosis vary depending on the specific condition, but share common ocular and systemic manifestations. In Fabry disease, which is X-linked, males are more severely affected. A hallmark ocular sign is the presence of cornea verticillata, whorl-like lines in the corneal epithelium. Systemically, patients often develop renal failure, painful neuropathic symptoms or dysesthesias, and angiokeratomas, reflecting the widespread impact of lipid accumulation. In multiple sulfatase deficiency, ocular findings include subtle diffuse corneal opacities, macular changes, and optic atrophy. Clinically, patients experience progressive psychomotor retardation, which unfortunately leads to a fatal outcome in the first decade of life. Tay-Sachs disease presents primarily with retinal abnormalities, most notably the classic cherry red spot in the macula, often accompanied by endothelial vacuoles. This condition is marked by severe neurodegeneration, significantly reducing life expectancy. The accompanying image demonstrates the cherry red spot typical of Tay-Sachs disease. The pathogenesis and diagnosis of sphingolipidoses are linked to specific enzyme deficiencies that cause harmful accumulation of lipids in various tissues. In Fabry disease, a deficiency of alpha-galactosidase A leads to the buildup of ceramide trihexoside in the renal and cardiovascular systems. This accumulation underlies the progressive organ damage characteristic of the disease. Generalized gangliosidosis, GM1, results from a deficiency of beta-galactosidases, causing the accumulation of ganglioside GM1 in the central nervous system and keratan sulfate in somatic tissues. This widespread deposition leads to neurological and systemic dysfunction. In Tay-Sachs disease, GM2 type, a deficiency of beta-hexosaminidase A causes the buildup of ganglioside GM2, primarily affecting the central nervous system and resulting in profound neurodegeneration. Laboratory evaluation plays a crucial role in diagnosis. In Fabry disease, reduced alpha-galactosidase A levels in urine or plasma are diagnostic, and conjunctival biopsy may show abnormalities even before cornea verticillata is clinically visible. For Tay-Sachs disease, inclusion bodies can be identified in conjunctival biopsies or blood leukocytes. Additionally, prenatal diagnosis through chorionic villus sampling and gene sequencing is possible, particularly for Fabry disease, allowing early detection and intervention. The management of sphingolipidosis focuses on both supportive care and targeted therapies, depending on the specific condition. In Fabry disease, genetic counseling is crucial, particularly for asymptomatic heterozygous carriers, to guide family planning and early detection.
The mainstay treatment is enzyme replacement therapy, ERT, with alpha-galactosidase A infusions, which can help clear corneal deposits and improve systemic manifestations. However, while corneal clarity may improve, the long-term benefit of ERT is still under evaluation. Additionally, newer therapeutic approaches are being explored, such as agents that stabilize native enzymes, potentially enhancing efficacy and reducing disease progression. For Tay-Sachs disease, where no effective curative treatment currently exists, management is largely preventative. The disease has a higher incidence in the Ashkenazi Jewish population, making genetic screening an invaluable tool for identifying carriers and reducing disease transmission. This proactive approach helps in early counseling and family planning.
Mucolipidoses, MLs, are a group of inherited autosomal recessive disorders of carbohydrate and lipid metabolism that share features with both mucopolysaccharidoses and lipidoses. These disorders are characterized by the accumulation of incompletely degraded glycosaminoglycans and other substrates due to defects in lysosomal acid hydrolase enzymes, leading to systemic and ocular disease. The clinical features of MLs commonly include progressive corneal clouding, which is observed in all subtypes, along with retinal findings such as the classic cherry red spot and progressive retinal degeneration. The severity and rate of progression vary depending on the specific subtype. From a pathogenetic perspective, MLs result from defective lysosomal enzyme function, causing incomplete degradation of macromolecules. This leads to the accumulation of sphingolipids in the retina and central nervous system, contributing to neurodegenerative changes and visual impairment. The subtypes of mucolipidoses include ML1, dysmorphic sialidoses, ML2, inclusion cell disease, ML3, pseudohurler polydystrophy, and ML4. Altogether, mucolipidoses illustrate the overlap between metabolic storage disorders with their hallmark ocular features, particularly corneal clouding and cherry red spots, serving as important clinical clues to diagnosis. In the evaluation of mucolipidosis, laboratory findings are key in distinguishing them from other inherited metabolic diseases. Plasma cells in affected individuals are often vacuolated, and plasma lysosomal hydrolase levels are elevated, reflecting abnormal enzyme trafficking. Histologically, the corneal epithelium demonstrates intracytoplasmic storage material, which can be sampled through biopsy. In ML4, where corneal clouding is present from birth, conjunctival biopsy may reveal characteristic intralysosomal inclusion bodies. These inclusions can take the form of single-membrane vacuoles containing fibrillogranular and membranous lamellar material, or lamellar and concentric bodies resembling those found in Tay-Sachs disease. Importantly, unlike mucopolysaccharidosis, there is no mucopolysaccharide urea or cellular metachromatia, which helps avoid diagnostic confusion. For ML2, prenatal diagnosis can be established through chorionic villus sampling, providing an opportunity for early detection in at-risk families. Management options for mucolipidosis remain limited. Traditional surgical approaches, including PK and LK, generally yield poor outcomes due to abnormal epithelial resurfacing and recurrence of storage material in the graft. As such, results are often disappointing. An emerging option under investigation is allograft limbal stem cell transplantation, which may provide improved epithelial health and visual outcomes, though evidence remains preliminary. In addition to the more well-defined lysosomal storage diseases, there are several miscellaneous disorders that also impact the cornea and anterior segment. However, these are likely low yield for your exam. We will discuss them nonetheless for completeness' sake. Among these are galactosialidosis, also known as Goldberg syndrome, manicidosis, and fucosidosis. Galactosialidosis is cathepsin-related and resembles both beta-galactosidase and sialidase deficiency, leading to overlapping clinical features. Manicidosis results from a deficiency of manicidase, which disrupts glycoprotein degradation and leads to systemic and ocular involvement. Fucosidosis, on the other hand, is caused by mutations in the FUCA1 gene, resulting in reduced or absent alpha-L-fucosidase activity. Interestingly, even when the cornea appears clinically clear, endothelial cells may demonstrate fibrillar, granular, multilaminated deposits, highlighting the importance of microscopic and laboratory evaluations in diagnosis.
Many of these conditions are associated with corneal clouding, which may be an important presenting sign and a clue to underlying systemic disease.
Hypolipoproteinemias represent a group of disorders characterized by an abnormal reduction in serum lipoprotein levels, typically inherited in an autosomal recessive manner. These conditions result in a spectrum of ocular manifestations, primarily related to corneal involvement. LCAT deficiency is one such disorder, where patients develop a peripheral arcus and stromal haze due to lipid deposition beginning in childhood, although vision is usually not severely affected. In contrast, fisheye disease presents with progressive corneal clouding caused by minute gray-white-yellow stromal deposits that begin peripherally and advance centrally, leading to reduced vision. Another important condition is Anterior disease, which produces diffuse corneal clouding and posterior stromal opacities. Unlike other lipid disorders, it does not feature a corneal arcus. Additionally, due to neuropathy, patients often develop lagophthalmos, predisposing them to corneal complications. Systemic findings in Anterior disease include large orange tonsils, hepatosplenomegaly, and lymphadenopathy. On the other hand, familial hypo-beta-lipoproteinemia and Bassan-Kornzweig syndrome do not cause corneal disease, but remain significant due to their systemic consequences. These disorders underscore how systemic lipid metabolism defects manifest as corneal changes, often serving as early diagnostic clues.
Laboratory evaluation of hypolipoproteinemias focuses on analyzing serum lipid profiles, where a characteristic finding is very low levels of high-density lipoprotein, or HDL. This reduction is particularly pronounced in Anterior disease, where HDL may be almost completely absent. Another pathognomonic laboratory feature is hypocholesterolemia, which serves as a key diagnostic clue in these patients. Management primarily centers around early recognition, as timely diagnosis allows for appropriate referrals and genetic counseling. These steps are crucial because hypolipoproteinemias are inherited conditions that may carry systemic and ocular consequences. The ophthalmologist's role lies not only in identifying ocular signs such as corneal clouding and arcus, but also in initiating multidisciplinary care to address systemic lipid abnormalities and guide family counseling.
This new section introduces inherited metabolic diseases involving amino acid, protein, nucleic acid, and mineral metabolism. These disorders represent a diverse group of systemic conditions that can manifest with important ocular and anterior segment changes. We will discuss each group individually, but as an overview, disorders of amino acid metabolism include conditions such as cystinosis, tyrosinemia, and alkaptonuria. In the category of protein metabolism, amyloidosis is the key example. Nucleic acid metabolism disorders include gout and porphyria, and mineral metabolic disorder is highlighted by Wilson disease. Let's start by talking about inherited amino acid metabolic disorders. Cystinosis is a rare inherited metabolic disorder that follows an autosomal recessive pattern of inheritance, occurring in approximately 35 per 10 million live births. The disease arises from mutations in the CTNS gene, which lead to defective lysosomal transport of cysteine. As a result, cysteine accumulates within lysosomes, most prominently in the eye and variably in the kidney and other organs. This abnormal storage is responsible for the systemic and ocular manifestations of the disease. There are two major categories of cystinosis. The first is nephropathic cystinosis, which is strongly associated with kidney involvement and can be further divided into infantile and juvenile forms. The infantile type represents the most severe disease, characterized by early-onset renal dysfunction, growth retardation leading to dwarfism, and significantly decreased life expectancy without treatment. The juvenile form is milder, with later-onset renal involvement but still associated with progressive systemic complications. The second category is non-nephropathic cystinosis, previously referred to as adult cystinosis. Unlike the nephropathic form, this type is not associated with kidney disease, and patients typically have a normal life expectancy. However, ocular manifestations are still an important hallmark of the disease, serving as a diagnostic clue across all forms. Cystinosis presents with both ocular and systemic manifestations, which vary depending on the age of onset and severity of the disease.
From an ocular perspective, one of the hallmark findings is the deposition of fine, iridescent polychromatic crystals within multiple ocular tissues, including the cornea, conjunctiva, iris, and trabecular meshwork. The most visually significant deposits occur in the anterior stroma of the cornea, where they cause photophobia, glare, and decreased vision. These deposits tend to be densest in the peripheral cornea. Over time, the accumulated crystals may result in recurrent corneal erosions, band keratopathy, and filamentary keratitis. In advanced cases, they may also contribute to peripheral corneal neovascularization and even secondary glaucoma. The clinical photograph provided highlights the diffuse stromal crystalline deposits characteristic of the condition. On the systemic level, the infantile nephropathic form is associated with renal Fanconi syndrome, which presents with impaired tubular reabsorption, leading to significant renal dysfunction. This form also causes growth retardation, with affected children often demonstrating stunted growth and progressive metabolic complications. The late-onset forms of cystinosis, in contrast, are generally less severe, with milder systemic involvement and slower disease progression. The diagnosis of cystinosis can be confirmed through laboratory testing, most notably by performing a conjunctival biopsy. The biopsy should be preserved in glutaraldehyde solution to avoid dissolving the cystine crystals. Under microscopy, the presence of these crystals within conjunctival tissue confirms the diagnosis. In terms of management, the primary therapeutic goal is to reduce cystine accumulation and prevent progression of ocular and systemic complications. The most effective treatment is topical cysteamine, 0.44%, which has been shown to significantly decrease crystal accumulation within the cornea. This therapy not only reduces the density of corneal deposits, but also helps relieve corneal pain and lowers the frequency of recurrent corneal erosions. For patients with posterior segment involvement, such as pigmentary retinopathy or optic nerve damage, oral cysteamine may be prescribed to target systemic and deeper ocular deposits. Overall, early recognition and targeted therapy play a critical role in preserving vision and improving quality of life in patients with cystinosis.
Cystinosis is certainly not the only cause of corneal crystals. A range of systemic conditions are associated with the presence of corneal crystals, including those that arise from lipid disorders, protein metabolism defects, immunoglobulin abnormalities, or other miscellaneous metabolic causes. Lipid keratopathies represent one major category. These include familial lipoprotein disorders, LCAT deficiency, Schneider corneal dystrophy, and Tangier disease. Disorders of protein metabolism can also produce corneal crystals. Conditions such as cystinosis, gout, hyperuricemia, and tyrosinemia lead to the accumulation of protein or amino acid-related crystalline material. In addition, immunoglobulin disorders are a significant group that may result in crystal deposition. These include benign monoclonal chemopathy, cryoglobulinemia, multiple myeloma, rheumatoid arthritis, and Waldenstrom macroglobulinemia. Finally, there are miscellaneous causes, which include calcium deposits, oxalosis, and porphyria. Each of these disorders represents a distinct metabolic pathway defect, but all share the feature of crystal deposition in the cornea that may serve as an early indicator of systemic disease.
Next, tyrosinemia is part of a group of inborn errors in tyrosine metabolism. There are two types, type 1 and type 2, both caused by a deficiency of the enzyme tyrosine aminotransferase. In type 2, excess circulating tyrosine results in ocular and systemic manifestations. Type 1, however, does not typically involve corneal pathology. The clinical presentation is dominated by ocular findings. Patients experience photophobia, tearing, conjunctival injection, and sometimes tarsal papillary hypertrophy. A hallmark feature is recurrent corneal erosions, often with pseudodendrites, which differ from true herpetic dendrites because they do not stain well with fluorescein or rose bengal. If unrecognized, these erosions can progress to corneal vascularization and scarring, leading to vision loss. In children, this condition should be considered if they are labeled as having recurrent bilateral HSV keratitis. In addition to ocular involvement, patients may present with hyperkeratotic skin lesions on the palms, soles, and elbows, as well as varying degrees of cognitive impairment. Diagnosis is made by demonstrating high tyrosinemia with tyrosinuria, while phenylalanine levels remain normal. Conjunctival biopsy can confirm the deficiency of tyrosine aminotransferase. Management consists primarily of dietary modification, with restriction of tyrosine and phenylalanine intake. This intervention has been shown to improve both ocular and systemic findings, and importantly, can still be effective even when treatment is initiated later in the course of the disease. The accompanying clinical image illustrates corneal pseudodendrites, which are a classic diagnostic clue in affected individuals. Alkaptonuria is a rare inherited metabolic disorder caused by a mutation in the HGD gene, which results in a deficiency of the enzyme homogentisic acid oxidase. This enzyme defect leads to the accumulation of homogentisic acid in the body. Over time, the excess homogentisic acid polymerizes into a dark pigment known as alkapton, which deposits into connective tissues through a process called achranosis. The clinical presentation often includes blue-black pigmentation within the corneal epithelium or Bowman's layer, especially near the limbus, as well as scleral pigmentation adjacent to the insertions of the extraocular muscle tendons. Systemically, patients develop a range of manifestations including arthropathy, renal calculi, and pigmentation of cartilage and connective tissues, notably in the ear, nose, heart valves, and prostate. Laboratory evaluation reveals elevated levels of homogentisic acid in the urine, a key diagnostic feature. A pathognomonic clue is that urine from affected individuals darkens on standing due to oxidation of homogentisic acid. At present, management is largely supportive, as there is no specific curative therapy. High-dose ascorbic acid may help reduce the progression of arthropathy by limiting homogentisic acid polymerization, although its efficacy is variable. Gene therapy is an area of active investigation and may hold promise for future treatment. The images provided show characteristic pigment deposition in the conjunctiva and sclera, as well as cartilage involvement in the ear, both classic signs of achranosis. That wraps up the most common inherited amino acid metabolic diseases. Let's now discuss protein-related inherited metabolic disease, in specific, amyloidosis. Amyloidosis is a systemic disorder characterized by the abnormal extracellular accumulation of amyloid proteins in various tissues and organs, including the cornea and conjunctiva. These amyloid deposits are insoluble and disrupt the normal structure and function of tissues by displacing healthy cellular components and impairing their physiologic activity. In the eye, amyloid deposition can present as corneal or conjunctival opacities, often progressive and vision-threatening. Diagnosis of amyloidosis relies heavily on histopathologic staining techniques, which highlight the unique properties of amyloid fibrils. Classic staining methods include Congo red, which demonstrates a characteristic positive reaction. When viewed under polarized light, Congo red stained amyloid exhibits apple green birefringence, a diagnostic hallmark. Additionally, other stains, such as crystal violet, can reveal metachromasia, while thioflavin T produces strong fluorescence under UV light, further confirming amyloid presence. These staining features are critical for distinguishing amyloid from other extracellular deposits and for establishing a definitive diagnosis. The figure provided illustrates these diagnostic properties, with tissue sections showing Congo red positivity and the distinct apple green birefringence under polarized light, consistent with amyloid deposition. Amyloidosis can be classified into primary and secondary, and localized versus systemic forms. They can also be broken down into hereditary and non-hereditary etiologies. The table is a summary of the various classifications, but we will get into each individually. The primary localized form is the most common type seen in the eye. It typically manifests as conjunctival plaques and includes rare corneal dystrophies such as gelatinous drop-like corneal dystrophy and lattice corneal dystrophy type 1. These localized deposits are confined to ocular tissues without systemic disease. The primary systemic form has much broader involvement. Patients may present with eyelid papules, vitreous opacities, pupillary abnormalities, or orbital and extraocular tissue deposits. A key association is with TTR gene mutations, transthyretin, on chromosome 18, which leads to familial systemic amyloidosis. One subtype, sometimes referred to as Marutoha syndrome, typically presents in the 3rd to 4th decade of life with distinctive clinical features. These include characteristic facial appearance, dermatochalasis, lag ophthalmos, nerve palsies, and dry, lax skin. Ocularly, corneal lattice lines spread from the limbus, more peripherally than centrally, leading to decreased corneal sensation and increased risks of glaucoma, dry eye, and recurrent erosions. The secondary form of amyloidosis is linked with chronic systemic diseases or ongoing systemic inflammation. In these cases, amyloid deposition in the eye reflects a broader systemic condition rather than a primary ocular disorder. The provided images illustrate the ocular and systemic features of amyloidosis. The upper image shows lattice lines in the cornea due to amyloid deposition, while the lower image demonstrates the typical facies seen in familial systemic amyloidosis, including dermatochalasis and changes in periocular tissues.
A classic example of secondary amyloidosis is multiple myeloma.
Familial amyloidosis is characterized by the pathological deposition of amyloid in ocular and systemic tissues. In the eye, discontinuous bands of amyloid accumulate under the Bowman layer and within the sclera, where they often present as lattice lines. These deposits are related to mutations in the gelsolin gene and can localize in the conjunctiva, sclera, ciliary body, choriocapillaris, ciliary nerves and vessels, and even the optic nerve. Beyond the eye, amyloid deposits also occur systemically in the arterial walls, peripheral nerves, and renal glomeruli, reflecting its widespread nature. Management requires a multidisciplinary team approach due to its systemic manifestations. Ocular subspecialists may address complications such as diplopia from cranial nerve dysfunction, vitreous involvement, and glaucoma. Conjunctival deposits are typically not treated, while recurrent corneal erosions may necessitate PTK, PK, or LK if significant visual dysfunction arises. However, despite intervention, the condition may recur, necessitating long-term follow-up and supportive care. Wrapping up amyloidosis, we're now going to talk about disorders in nucleic acid metabolism, which include gout and porphyria.
Gout is a purine metabolism disorder that causes hyperuricemia and deposition of urate crystals. Ocular manifestations may include acute inflammation of the sclera, scleritis, episclera, episcleritis, or conjunctiva, causing conjunctivitis, as well as corneal epithelial or stromal deposits without inflammation. Rarely, it can present as band keratopathy. The etiology may be familial, related to enzyme deficiencies, such as in Lesch-Nyhan syndrome, or secondary to factors like chemotherapy, excessive alcohol consumption, or myeloproliferative disease. A key clinical pearl is that serum uric acid levels are typically elevated but can be normal in cases of urate keratopathy without inflammation. Management includes NSAIDs, for example indomethacin, or colchicine for acute attacks, allopurinol for chronic uric acid reduction, and mechanical removal of corneal deposits if necessary. Porphyria refers to a group of heme synthesis disorders caused by a deficiency of uroporphyrinogen decarboxylase, leading to excess porphyrin production. The disease is often triggered in middle age by liver insults such as alcohol or drug exposure. The most common form that is associated with ocular surface disease is porphyria cutanea tarda. Ocular manifestations include hyperpigmentation, erythema, and scleroderma-like skin changes. The eyes may show vesicular or ulcerative lesions on the conjunctiva and cornea, with scarring and symblepharon resembling bullous pemphigoid. Some of these changes can be seen in the picture above. Conjunctival necrosis, corneal thinning, and even perforation at the limbus can occur. Laboratory evaluation typically demonstrates hepatocytes filled with corphorins that fluoresce bright red under UV light in a hepatic biopsy. Additionally, urine turns dark when exposed to light. Management focuses on UV protection and iron reduction therapy via phlebotomy or deferoxamine. No specific ocular treatment exists, but artificial tears may provide symptomatic relief. The last category of inherited metabolic diseases include those involved in mineral metabolism, particularly Wilson disease. Wilson disease is a disorder of abnormal copper deposition in the liver, brain, and ocular structures caused by a mutation in the ATP7B gene. Clinical features include hepatic and neurologic symptoms such as Parkinson-like movements, speech changes, and dementia. Ocular findings are key and include the Kayser-Fleischer ring, seen in Figure A as a golden brown, ruby red, or green pigment in the peripheral deciment membrane. While characteristic, it is not pathognomonic as it may occur in other liver diseases. Another classic feature is the sunflower cataract, seen in Figure B, along with evidence of retinal dysfunction. Diagnosis and management rely on laboratory tests, which show low ceruloplasmin levels and high serum and urine copper. Treatment includes penicillamine to chelate copper and, in severe cases, liver transplantation. A useful monitoring sign is the disappearance of the Kayser-Fleischer ring with successful therapy. That completes the section on inherited metabolic disorders, so we will now change topic to discuss skeletal and connective tissue disorders that have ocular manifestations. Ehlers-Danlos syndrome is a group of heterogeneous connective tissue disorders characterized by joint and skin hyperextensibility, easy bruising, and cigarette paper scars. The condition arises from defects in collagen type 1 or 3 synthesis and may also result from lysyl hydroxylase deficiency, notably in EDS type 6, the ocular scoliotic type, which is strongly associated with ocular findings. Ocular manifestations include corneal complications such as keratoconus, keratoglobus, and brittle cornea, which may rupture even with minor trauma. This can lead to easy bruising and brittle cornea syndrome that is sometimes mistaken for child abuse. Other features include epicanthal folds, blue sclera, glaucoma, and ectopia lentis, while retinal involvement may present as retinal detachment or angioid streaks. EDS type 6 carries particular caution as it is associated with mitral valve prolapse, bowel rupture, and complications during strabismus surgery. Diagnosis is made clinically and supported by the demonstration of hydroxylysine deficiency in the dermis or an altered urinary lysyl-pyridinoline ratio. Treatment is focused on surgical support such as patch grafts for corneoscleral ruptures. Additionally, genetic counseling is recommended due to the hereditary nature of the disorder. Marfan syndrome is an autosomal dominant connective tissue disorder caused by mutations in the FBN1 gene, which encodes fibrillin-1. Abnormal fibrillin synthesis disrupts the extracellular matrix. Since fibrillin is present in the corneal basement membrane, zonular fibers, lens capsule, and sclera, its deficiency leads to significant ocular and systemic manifestations. Systemic involvement commonly includes the cardiovascular system with aortic dilation and aneurysms, and the skeletal system, presenting with arachnodactyly, pectus excavatum, and kyphoscoliosis. Ocular manifestations are prominent and include lens subluxation, typically superotemporal, along with blue sclera due to scleral thinning, corneal flattening, and increased risk of early-onset open-angle glaucoma and cataracts. Management emphasizes critical cardiac evaluation, as premature mortality often results from aortic complications if left untreated. For ocular care, management of lens subluxation involves advanced cataract surgery techniques such as the use of capsular tension rings or scleral fixation. In severe cases, a pars plana approach may provide a safer method for lens removal. Osteogenesis imperfecta is a rare autosomal dominant connective tissue disorder caused by mutations in the COL1A1 and COL1A2 genes, which impair collagen synthesis. This systemic condition affects the skeleton, teeth, skin, joints, hearing, and eyes. Clinically, OI presents with brittle bones prone to multiple fractures, dental fragility, and conductive or sensory neural hearing loss that typically begins in adolescence. Ocular manifestations include blue sclera, which is present throughout life in type 1 but may fade in other types. Additional corneal findings are reduced central corneal thickness, keratoconus, and megalocornea. Skull fractures may also cause optic nerve damage, contributing to visual morbidity. It is essential to consider osteogenesis imperfecta in infants or children presenting with fractures suspicious for non-accidental trauma, as misdiagnosis can have significant implications. Management is multidisciplinary. Oral bisphosphonates are used to reduce bone resorption, while aggressive orthopedic intervention addresses recurrent fractures. Supportive care with low-impact physical activity helps preserve musculoskeletal function and reduce fracture risk. Blue sclera can result from a variety of local, systemic, and medication-related causes. Local factors include high myopia, prior necrotizing scleritis, oculodermal melanocytosis, or nevus avuta, previous ocular surgeries, and naturally thin sclera in neonates. Systemic conditions strongly associated with blue sclera include inherited and metabolic disorders such as alkaptonuria, brittle cornea syndrome, Ehlers-Danlos syndrome type 6, hypophosphatasia, Marfan syndrome, osteogenesis imperfecta, and primary adrenal insufficiency, Addison's disease. Finally, medications may also contribute to scleral discoloration, with important culprits including amiodarone, antimalarials, minocycline, and phenothiazines. Goldenhar-Gorlin syndrome, also known as oculo-auriculovertebral (OAV) syndrome, arises from anomalous development of the first and second branchial arches. Clinically, it presents with hemifacial microsomia due to underdevelopment of facial structures, seen in the top right picture, hearing difficulties often accompanied by oral fistula, scoliosis secondary to incomplete vertebral formation, and preauricular appendages. Ocular manifestations are common, with limbal dermoids being the most frequent finding depicted in the picture on the left. These dermoids are chorostomas containing fibrous and fatty tissue and may also include hair and sebaceous glands. They can involve the entire cornea and cause amblyopia through significant corneal astigmatism, although they are not pathognomonic for Goldenhar-Gorlin syndrome. Other ocular findings may include upper eyelid colobomas and strabismus. Management of dermoids focuses primarily on cosmetic and visual rehabilitation. Shaving the elevated portion may improve appearance but does not address the deeper corneal or scleral involvement, nor does it resolve associated astigmatism. Contact lenses may improve vision, while surgical excision alone risks significant scarring. LK may be considered as an alternative approach to reduce scarring and improve outcomes. Next, let's talk about nutritional disorders that have ocular manifestations, specifically vitamin A deficiency. Vitamin A deficiency is a major public health issue and remains the leading cause of blindness in malnourished countries. The earliest clinical manifestation is night blindness, which results from impaired rhodopsin production in the retina. Several risk factors contribute to this deficiency. Malnutrition is a key driver, particularly in infants and children of vitamin A deficient mothers. Decreased absorption can also occur in chronic alcoholism, lipid malabsorption syndromes, and after gastric bypass surgery. Additionally, concurrent corneal infections such as herpes simplex, measles, or bacterial infections increase susceptibility, predisposing to keratomalacia, a severe corneal complication. The pathogenesis involves multiple mechanisms. Vitamin A deficiency inhibits rhodopsin production, leading to night blindness. It also impairs mucus production by goblet cells, resulting in cirrhosis or abnormal dryness of the ocular surface. Beyond the eye, the deficiency disrupts epithelial cell function across various organ systems, including the gastrointestinal, genitourinary, and respiratory tracts. Ocular manifestations of vitamin A deficiency are classically identified by the presence of Beteaux spots, which are superficial, dry-appearing, foamy, gray triangular lesions found on the bulbar conjunctiva near the limbus. These lesions are composed of keratinized epithelium, inflammatory cells, cellular debris, and the bacterium Cornebacterium cirrhosis. With progression, severe cirrhosis can advance to keratomalacia, a sight-threatening condition. Management of vitamin A deficiency is urgent, particularly when associated with keratomalacia, as this represents a medical emergency with up to 50% mortality if untreated. Treatment involves oral vitamin A supplementation combined with protein-calorie support to address the underlying nutritional deficit. Supportive corneal care is equally important, including lubrication to maintain surface integrity, measures to prevent secondary infection, and protection against keratolysis. Most critically, identifying and addressing the root causes of vitamin A deficiency, whether malnutrition, absorption issues, or concurrent infections, is essential for both ocular and systemic recovery. The top two photos demonstrate the classic presentations of Bateau spots, while the bottom figure demonstrates severe cirrhosis progressing to keratomalacia. Hematologic disorders, specifically those that are related to excess circulating immunoglobulins, have distinct ocular features. Hematologic disorders, such as multiple myeloma, Waldenstrom macroglobulinemia, and benign monoclonal gammopathy, are characterized by the excess synthesis of immunoglobulins, and these systemic abnormalities often present with distinct ocular manifestations. One of the more common findings is crystalline corneal or conjunctival deposits, which result from abnormal deposition of immunoglobulin light chains. These deposits can mimic inherited corneal dystrophies but usually appear later in life in the context of systemic disease. Another significant manifestation is copper deposition, which is most classically seen in Wilson disease but can also be encountered in hematologic conditions. Copper accumulates in ocular structures, leading to the appearance of a Kayser-Fleischer ring, a golden brown to greenish pigment deposited in Descemet's membrane at the corneal periphery, as well as the development of sunflower cataracts, which display a central opacity with radiating spokes. Hypervistosity from elevated immunoglobulin levels can cause vascular sludging, which manifests as engorged retinal veins, hemorrhages, and ischemic changes in the fundus. Less commonly, patients may develop pars plana cysts associated with lymphoid or hematologic infiltration or scleral infiltration from direct plasma cell or lymphoproliferative involvement, which can compromise ocular integrity. In more advanced cases, orbital invasion may occur, presenting with proptosis due to the spread of plasma cell tumors or other hematologic malignancies. This orbital disease can mimic other conditions, such as thyroid eye disease or orbital pseudotumor, making accurate systemic correlation essential. The next slide contains a video from the AAO that shows a slit lamp demonstration of corneal stromal cysts from multiple myeloma. Hematologic diseases can produce a range of corneal and retinal findings due to abnormal plasma cell activity and altered serum viscosity. In multiple myeloma, a single clone of plasma cells secretes IgG kappa chains that form striking, polychromatic, scintillating crystalline deposits throughout the cornea. Waldenstrom macroglobulinemia involves malignant IgM-producing plasma cells and is associated with hyperviscosity. The cornea shows needle-like or amorphous stromal deposits, as shown here. Benign monoclonal gammopathy causes only mild paraprotein elevation, but a small percentage of patients can still develop iridescent corneal crystals. And finally, cryoglobulins, cold precipitating proteins seen in autoimmune or viral diseases, can lead to crystalline corneal deposits, limbal masses, and even retinal changes from hyperviscosity.
This is a slit lamp view of cornea crystals in a case of smoldering multiple myeloma. Starting at low magnification, you can see multiple fine refractile bodies within the cornea. The light reflex from the slit lamp, as well as the side illumination light, are also visible. At higher magnification, these crystals are seen as spindle-shaped and reflective. With a broad oblique beam, these bodies are visible from limbus to limbus. An angled, slender slit beam demonstrates their uniform presence throughout all layers of the cornea. Here, the light is focused on the iris. Note, no crystals are seen on the iris. Moving to the fellow eye, the appearance is the same, which is consistent with its systemic origin. Future cornea biopsy with immunohistochemical stains indicated these crystals were kappa light chain proteins, confirming this case of smoldering multiple myeloma.
Hematologic disorders that affect the eye are rooted in abnormal plasma cell proliferation, which leads to the overproduction of light and heavy chain proteins. When both heavy and light chains are produced, they form M proteins, while the presence of only light chains results in Bence-Jones proteins. In rare cases, heavy chains alone may lead to heavy chain disease. The ocular manifestations of these conditions can occur either due to direct pathologic tissue invasion, such as into the bone marrow, or from systemic effects like hyperviscosity. These disorders are often associated with secondary hypercalcemia. Corneal paraprotein deposition, though rare, may be a key ocular finding, and the location and specific appearance of these crystals can help distinguish between different etiologies. Laboratory evaluation is essential and includes serum protein electrophoresis, complete blood counts, albumin and globulin measurements, and calcium levels. Additional systemic testing is guided by clinical suspicion and the findings on initial workup. From a management perspective, ophthalmic treatment is usually not required. However, if the crystalline deposits impair vision significantly, surgical removal using LK may be necessary. Importantly, these deposits typically resolve slowly once the underlying malignancy has been treated, making systemic management a cornerstone of care. As we wrap up the last two topics, we will discuss endocrine diseases, including diabetes, multiple endocrine neoplasia, and parathyroid disease. Diabetes is associated with a variety of corneal complications, collectively referred to as diabetic keratopathy. The clinical presentation often includes punctate epitheliopathy, erosions, hypoesthesia, persistent epithelial defects, and corneal edema. These changes tend to occur more frequently and with greater severity in patients with long-standing diabetes. Delayed corneal healing is another hallmark feature. Additionally, weight Beetham lines may be observed, which likely reflect early endothelial dysfunction and hydration changes, though they are not pathognomonic. Laboratory evaluation is guided by systemic diabetic control, with elevated A1C serving as a key indicator of disease severity and chronicity. Management is largely supportive and focuses on improving corneal health and healing. This includes treating meibomian gland dysfunction, ensuring adequate lubrication, avoiding toxic medications, and performing gentle epithelial debridement when necessary. Therapeutic contact lenses may also be used, though caution must be exercised due to the increased risk of infection in diabetic patients. Importantly, the presence of diabetic keratopathy is not a contraindication to cataract surgery or penetrating keratoplasty as long as the patient is medically stable. However, LASIK is contraindicated in cases with poor epithelial adherence or reduced corneal sensation, as these factors significantly increase the risk of postoperative complications and impaired healing. Multiple endocrine neoplasia, MEN, refers to a group of conditions characterized by tumors arising in two or more endocrine glands, which may be either benign or malignant. There are three main types: MEN1, MEN2A, and MEN2B, each associated with distinct clinical features. The underlying pathogenesis involves mutations in the RET gene, and inheritance follows an autosomal dominant pattern. In terms of clinical presentation, MEN1 commonly involves tumors of the pituitary, parathyroid, and pancreas. These can result in visual field defects secondary to pituitary masses compressing the optic chiasm. MEN2A is characterized by medullary thyroid carcinoma, pheochromocytoma, parathyroid, and enlarged corneal nerves, which are often an early ocular clue. MEN2B includes medullary thyroid carcinoma, pheochromocytoma, mucosal neuromas, and marfanoid habitus, also with the presence of enlarged corneal nerves as a recognizable ocular finding. Management requires a multidisciplinary approach. Patients need ongoing follow-up with endocrinologists to monitor and treat hormone deficiencies. In MEN1, neurological testing and possible referral to a neurosurgeon may be warranted for pituitary masses. For MEN2, hypertension should prompt screening for pheochromocytoma, while the presence of a neck mass requires evaluation for medullary thyroid carcinoma. Early recognition of ocular signs, such as enlarged corneal nerves, can serve as a valuable diagnostic clue for systemic disease.
Enlarged corneal nerves can be a significant ocular finding and may be associated with both systemic and ocular diseases. Systemic conditions linked to this presentation include multiple endocrine neoplasia type 2B, Refsum's disease, a phytanic acid storage disorder, Hansen disease, leprosy, which often produces beating of nerves, familial dysautonomia, such as Riley-Day syndrome, and neurofibromatosis. Among ocular diseases, enlarged corneal nerves may be seen in keratoconus, ichthyosis, Fuchs endothelial corneal dystrophy, corneal edema, congenital glaucoma, and acanthamoeba keratitis with perineuritis. The mnemonic man-erk-girl is a helpful way to recall the causes of enlarged corneal nerves. Here, MAN stands for MEN2, acanthamoeba, and neurofibromatosis. IRK represents ichthyosis, Refsum's disease, and keratoconus, while GIRL reminds us of glaucoma, congenital, idiopathic, Riley-Day syndrome, and leprosy. The figure highlights the classic branching pattern of corneal nerves. Parathyroid disease can present with ocular manifestations, most notably band keratopathy, which is characterized by calcium deposition in the cornea, specifically within the Bowman layer. The pathogenesis can be primary or secondary. Primary hyperparathyroidism is usually due to benign chief cell proliferation, though it is rarely associated with multiple endocrine neoplasia. Secondary causes include renal disease, which leads to calcium loss and a compensatory increase in PTH, as well as conditions such as milk alkali syndrome, sarcoidosis, or excess vitamin D intake. Importantly, calcium deposits can develop in the cornea even when systemic calcium and PTH levels are normal. Management is generally only required if the deposits cause decreased vision or discomfort. In such cases, calcium removal can be performed with chelation therapy using EDTA to improve comfort and restore corneal clarity. Lastly, let's wrap up by talking about 3 dermatologic conditions that have ocular manifestations: ichthyosis, ectodermal dysplasia, and xeroderma pigmentosum. Ichthyosis refers to a group of hereditary skin disorders characterized by dry, scaly skin. The most common form is ichthyosis vulgaris, which follows an autosomal dominant inheritance pattern, while X-linked ichthyosis is less common but often associated with ocular changes. The clinical presentation includes eyelid scaling, cicatricial ectropion, and conjunctival thickening. Corneal opacities are frequently seen in X-linked ichthyosis but are rare in the vulgaris form. Dot-like stromal opacities may develop and tend to increase with age, though vision is usually preserved. In more severe cases, nodular corneal degeneration and band keratopathy can occur. Secondary complications, such as vascularization and scarring from exposure keratopathy, may further compromise the cornea. Management focuses on hydrating the skin and eyelids and removing scales. Treatments that slow epidermal turnover may also help improve symptoms. However, these conditions are not responsive to corticosteroid therapy. The top image shows the back of a patient with widespread scaling of the skin, typical of ichthyosis. The skin appears dry and thickened with prominent plate-like scales, illustrating the hallmark systemic involvement of this hereditary condition. The bottom image shows the ocular involvement of ichthyosis, focusing on the eyelids and ocular surface. There is scaling around the eyelids with associated redness and thickening, and a dot-like corneal stromal opacity demonstrating the chronic eyelid, conjunctival, and corneal changes seen in affected patients. Ectodermal dysplasia is a rare, hereditary, non-progressive disorder present at birth that involves variable defects in the development of ectodermal structures, such as hair, nails, teeth, and sweat glands. Because of this abnormal morphogenesis, patients often present with systemic and ocular abnormalities. Clinically, patients may show sparse eyelashes and eyebrows, blepharitis, and ankyloblepharon, which is the adhesion of the eyelid margins. Hypoplastic lacrimal ducts lead to decreased tear production, and abnormal meibomian glands contribute to a dry conjunctiva. Ocular surface disease is common and may manifest as pterygia, corneal scarring, and neovascularization. In addition, patients may develop cataract and glaucoma. Many of these ocular changes are thought to be related to underlying limbal stem cell deficiency. Management involves tear replacement and preservation to address ocular dryness, along with eyelid hygiene to control blepharitis. In severe cases, a keratolimbal autograft with or without penetrating keratoplasty may be considered to restore ocular surface function and improve vision. Xeroderma pigmentosum is a rare autosomal recessive disorder that results from defective repair of UV-induced DNA damage. This leads to extreme photosensitivity and a markedly increased risk of malignancy. Patients present early with focal hyperpigmentation, atrophy, actinic keratosis, and telangiectasia. As the disease progresses, cutaneous neoplasms such as squamous cell carcinoma, basal cell carcinoma, and melanoma become common. Ocular manifestations are significant and include keratopathy, ulceration, scarring, neovascularization, and in severe cases, corneal perforation. Additional ocular features may involve keratoconus, corneal dystrophy, photophobia, tearing, and blepharospasm. The eyelids may also demonstrate atrophy, matarosis, trichiasis, scarring, symblepharon, and malpositions such as entropion or ectropion. Importantly, ocular neoplasms develop in approximately 11% of patients, particularly limbal squamous cell carcinoma. Management is centered on strict UV protection, including the use of sunscreen and protective clothing to minimize DNA damage. Lifelong monitoring is necessary to screen for both skin and ocular malignancies, allowing for early detection and intervention. On the right side of the slide, there is a clinical image of a young patient with significant cutaneous changes. The photo highlights the consequences of chronic UV-induced damage with visible hyperpigmentation, ulceration, and malignant transformation on the face. These findings reinforce the extreme photosensitivity and high risk of malignancy that define this disorder. In this chapter, we explored a wide range of systemic and metabolic disorders with corneal and ocular manifestations. We reviewed lysosomal storage diseases, inherited metabolic conditions, hematologic disorders, endocrine diseases, and dermatologic syndromes, all of which demonstrate how systemic pathology can uniquely present in the eye. By recognizing these ocular signs, whether corneal crystals, blue sclera, vascular changes, or epithelial abnormalities, we gain important insight into broader systemic disease and patient management. Thank you for your attention and engagement in this material, and I hope this knowledge strengthens both your understanding and clinical practice. See you in the next chapter.